Alright, welcome to this short little video about cuff pressures and endotracheal tubes and how to do them safely for your patient. So first, just the basics of an endotracheal tube. We have the end here that will connect to your ambu bag or your patient circuit. This here is called your pilot balloon, and that goes through all the way through to your cuff. And then you've got your end of your tube with your holes, a small Murphy eye, and then the main end. The cuff does not function to keep the tube in place, as many people falsely assume, but rather the cuff functions to ensure you have a good seal when you're giving positive pressure ventilation, as well as to reduce your aspiration risks. So before you intubate, first of all, always try to keep your tube sterile. Don't just lay it on the counter like I'm doing here. Keep it in the package as much as possible. But you want to check your cuff to make sure it's patent. 10cc syringe hooked up, you can inflate your cuff, and you can see this balloon here at the end is inflated, and you can squeeze it. It's always good to do this beforehand. Squeeze, make sure no air is escaping, there's no leaks here, and that this spring here is keeping the seal. So this tube is good, and you can see with 10 cc's, this balloon gets quite full. There's different styles of tubes. Some have larger volumes, and that doesn't necessarily mean more pressure, but a larger volume may mean that you may need to add more air to check your tube, but that doesn't always translate to more air in the endotracheal tube, and I'll show you why. So for our demonstration here, we have lungs, and this is going to be our trachea, okay? So what I can do here is intubate this trachea. I've deflated the cuff, and I'm going to intubate this trachea, get that tube all the way in, and now, normally with intubation, we quickly hook up to the vent, and we take your 10cc syringe and you inflate. And often people put in the whole 10 cc's right away, and that's fine for starting out. So now you take your stethoscope and you auscultate to confirm tube placement, right? So you listen, stomach, left lung, right lung. And now often people say, okay, I'm done. They might take this and they might squeeze it and say we're good. But that's not the best way to do things. And what we want to do is something called minimal occluding volume, which is finding out the least amount of volume needed to keep the sealing against the walls of the trachea, but not too much, because if we give too much pressure, we're going to cause tracheal stenosis in the future, whether weeks or months, and damage to that trachea, which we want to avoid. So what I'm going to do is put my stethoscope on the trachea and slowly deflate that cuff until I start to hear a leak with my stethoscope as I pull that air back. And so you've noticed, now I'm starting to hear a leak. You can hear that faint psh, and I could hear it with my stethoscope ahead of time. Now I'm gonna add a little bit of air till that leak goes away. I no longer hear it with my stethoscope. And we call that minimal occluding volume. And what that does is it shows you the least amount of air needed to occlude the trachea so air does not escape. And so you can see by squeezing this, it looks fine. But this is a much more objective way of knowing. So what's interesting to note from that minimal occluding volume is initially we had put a full 10 cc's of air in. Now if I reset my syringe and just put it at 0 and just deflate completely, you can see that it only took about 8 cc's of air to inflate this balloon. And this is going to be different depending on the size of your trachea. If you have a smaller trachea, this corrugated tubing is quite large. You can see there's a lot of space, even though as I tried to make it smaller, around the tubes. So it takes 8 cc's is actually a lot of air. Some patients might only need 2 or 3 cc's of air to get that occlusion. And so that is okay. Whatever is needed is adequate. So an alternative to minimal occluding volume is something called a cuff manometer, which is what you can see here. And this is a product that has a pressure gauge that connects to the pilot balloon. So you can actually measure your pressure. And the goal pressure is this blue zone between 20 and 30 centimeters of water. So we've just done our minimal occluding volume. Let's see if we are accurate. So you can see we're right there in that 20 zone. To demonstrate for you why doing this does not always work. So if you do this, you think, oh, it feels fine. I don't have a leak. But if you have not done your minimal occluding volume and you don't have a pressure manometer, you really have no way of knowing if it's okay. And let's pop it on the pressure manometer and see what this, which looks fairly, fine. Let's see what this pressure is. Here we are, that's a pressure of 80. So we're definitely reducing blood flow in this area, and we have a high risk of tracheal stenosis. And so again, we do that minimal leak technique. I can also do it on the cuff manometer by just slowly releasing air here. And you can see that pressure gauge starting to fall. And again, I'm listening for that leak with my stethoscope that's there. There, I'm starting to get a leak, right? You can hear that leak, so maybe add a little bit of air. And there we go, we're at 25 to 30 and we no longer have a leak. And so a pressure manometer can be helpful, but it generally gives you similar pressures to minimal occluding volume. And our goal with this is always to use the minimum amount of air needed to maintain a seal. And so we can get that with minimal occluding volume. So please, once your patient is intubated, immediately after intubation, it's fine. Add the 10 cc's of air or whatever, whoever is assisting you adds, that's fine. However, once you've confirmed placement and everything is fine, the patient is stable, probably on the vent, go back and do this minimal occluding volume. So again, you hook up your 10 cc syringe to your cuff and you just you hook it up to your pilot balloon and you slowly deflate until you hear that leak. Once you have that leak, go back and add that air. Add half cc, 1 cc of air so that leak goes away and stays away. If you have a patient on high amounts of PEEP or needing high pressures, they may need a little bit more. And again, here when we're listening to the leak, you hear that psh. On a patient, when you're listening with their neck with your stethoscope, you're going to hear a gurgly sound as well, and that's those secretions. You may also see a change in tidal volume, and that all indicates a leak. If you come back to your patient later on and you hear they have a leak, before you just go and add more air to their tube, always go back and check your tube depth. So endotracheal tubes all have these markings, 21, 23, 25. Always keep track of what your depth was when you intubated. If your tube is coming out and it's sitting high up and no longer in the trachea, maybe the tip of your tube is in the trachea, but the rest of the tube is in the oropharynx, it doesn't matter how much air you add to that cuff, it's not going to occlude your oropharynx. So instead of a default position of adding air every time you hear a leak, always confirm tube placement first. Thanks for watching. I hope this was helpful.